Hello everyone, my name is Sarah Zeeth and I am the Digital Marketing Specialist here at School Health Corporation. I want to start off by thanking you for joining us today and participating in the Year of Children's Vision webinar series. I would like to review a few things about today's webinar before handing it off to Dr. Jean Ramsey and the presenters. The presenters are planning to take about 40 to 45 minutes for their presentation, after which we will answer questions. We will not be taking audio questions, but would like you to submit your questions via the questions interface in GoToWebinar. You may submit your question at any time during the webinar. If your question is directed to a specific presenter, please include his or her name in the question. The webinar will be recorded, and a link to it with other resources will be emailed to you in 2 to 3 business days. And everyone who attends today's webinar will receive a certificate of attendance. And with that, I would like to hand it off to Dr. Ramsey.
Well, thank you very much. So welcome, all of you, to the Year of Children's Vision webinar series. And today we will be discussing how all of us can develop a strong vision health system for children. You may be interested in knowing that as of a while ago, we have had over 1,000 registrants for this webinar. And this, to me, is indicative of the great interest in children's vision in the United States, but also worldwide. So thank you all for joining us. This educational webinar today is being hosted and funded by School Health Corporation and is presented by the American Association for Pediatric Ophthalmology and Strabismus as part of the Year of Children's Vision. My name is Dr. Jean Ramsey, and I am a pediatric ophthalmologist, and I work at Boston University School of Medicine, and I will be your moderator today. Let me say a few words about what this organization is. APOS is the professional organization for pediatric ophthalmologists. And what is a pediatric ophthalmologist? A pediatric ophthalmologist is a medical doctor who has graduated from medical school, completed a 1-year internship, then 3 years of residency training, and an additional year of fellowship training in pediatric eye diseases. So APOS is extremely proud to be a member of this team that has developed this initiative for the Year of Children's Vision. The other partners in this initiative are the National Head Start Association, Good Light, School Health Corporation, and the National Center for Children's Vision and Eye Health at Prevent Blindness America. It's also supported by other leading national organizations such as the American Academy of Optometry. The goal of this initiative, and indeed it is a lofty goal, is to provide national guidance for all of you around the country and around the world who are working within early childhood programs, screening children's vision, and developing systems to ensure that all children are allowed the opportunity to develop their maximum visual potential. And of course, ensuring optimal vision for all children is more than doing a vision screening correctly, although that's important. And it's more than establishing communications between and among everyone involved in the care of the child. There are many components to this system, and all of them must be in place in order for us to be successful. This slide identifies 12 components that need to be attended to. Today, we'll be focusing on those components that are highlighted in color. The other components will be the topic of a webinar in the near future. You can find these components on the Year of Children's Vision website and you can examine them in more detail. So at the end of the session today, you should be able to feel confident that you can select vision screening methodology, whether it be acuity-based or instrument-based, that's age-appropriate and evidence-based. You should recognize the importance of developing these procedures and policies, which will allow everyone involved in the care of the child to be in communication. And you should be able to create appropriate policies for how we deal with the screening or referral of children with special needs or children who are difficult to screen. So today, Dr. Jeff Bradford, a professor of ophthalmology and pediatrics, will be discussing the importance of shared communication and documentation. And Dr. Kay Nottingham Chaplin, Director for the Vision and Eye Health Initiatives at Good Light, will be discussing evidence-based vision screening, protocols, and guidelines. And Dr. Linda Lawrence, Assistant Clinical Professor of Ophthalmology, will discuss what should you do when you have children who are difficult to screen or children who have special health care needs. Dr. Bradford will start the discussion today. And he is a pediatric ophthalmologist at West Virginia University. Dr. Bradford established the West Virginia Vision Institute, working with Dr. Chaplin. And this is to provide training and support for vision screening to primary care providers, school nurses, and Head Start personnel in the state. He has worked in this field a long time. So welcome, Dr. Bradford.
Thank you, Dr. Ramsey, very much. It's my pleasure to be a presenter in this webinar this afternoon, and I'd like to welcome all those who are logged in and participating this afternoon. So my goal this afternoon is to look at the 12 component system, and I will elaborate a little bit further once I advance my slide here. So Sarah, if you can hear me, there we go. Thank you very much. So of the 12-point system that Dr. Ramsey enumerated, I'm going to be talking about the 2nd point, the 9th point, the 10th point, and the 11th point. Specifically, the 2nd point, ensuring that parents and caregivers provide you with written approval for vision screening. This allows you then, once you've done the vision screening, to share those results with the child's eye doctor, especially if the vision screening result was a failed vision screening. You can also then be able to share the results with the child's pediatrician, family doctor, or perhaps another primary care provider. Having this documentation in place also allows you to get eye exam results for your own files so that you can understand why the child failed your vision screening. And good documentation will allow you to talk with the child's eye doctor for clarification of the eye exam results and the treatments that the eye doctor has prescribed for that child. Keeping the eye exam results in your files, you need permission from the families to be able to do that. And as I noted above, sending a copy of the eye exam results to the child's primary care provider is also something important to do. And the 11th bullet ensuring that the eye doctor's treatment plan is followed. If you understand the reason for the failed vision screening and you have a report back from the eye doctor, you certainly have an opportunity then to offer support and encouragement to the family so that that child's vision problem can be best addressed. So it's not just the importance of documentation, it's the importance of communication. And the take-home message, I think, from my section is just these two things. Communication. Communication between you and the child's family. Communication between you and the family and the child's pediatrician. And in the event of a failed vision screening, communication between the you and the family and the child's eye doctor. So communication and documentation. So of these 4 bullets, you can kind of digest them into 3 areas. You'd want to have good documentation setting up prior to doing the screening. You'd want to be able to do the screening and document the results, of course. And then after the screening, you'd want to be able to close the loop. And that's what we'll be talking about over the next few minutes here. So setting up the documents for screening. Setting up means that you take the time and assure that you have the parents' written consent. Consent for what? Consent to share the screening results with the pediatrician, with the eye doctor. Consent to receive the eye exam results from the eye doctor back to your office so that you can put those results into the files for that child. It's nice to have the parents' written consent so that you can talk with the doctors, the pediatrician and the eye doctor. And then also the parents' permission to share the eye exam results with the primary care provider. The parents should also be able to share those results, of course, but in the busy everyday world, it often falls between the cracks, that sort of communication. And if you have consent to be able to provide that information, that's very helpful as well. After the vision screening is done, and I'm jumping forward here because Dr. Chaplin will be on in a few minutes talking about the screening itself. But after the screening is completed, you'd want to be able to get the eye exam results back for your own files, and you'd want to send a copy of the results to the primary care provider if the eye doctor themselves doesn't do that. And then finally, working with the parents to implement the treatment, as I mentioned before. The more common types of treatment that we'll often see when children have an eye problem early in their childhood would include things like patching or using atropine eye drops to penalize the good eye if a child has an amblyopic or bad eye on the opposite side. Children will often need to be wearing a pair of glasses as part of their treatment for their eye issue, and if you're able to help the parents in suggesting where to get glasses and how to help their child wear their glasses adequately, you can be a good resource for families in this manner. One of the big obstacles about vision screening is getting the parents to actually attend the eye doctor's visit if their child failed a vision screening. And so helping the family keep the appointment, the initial appointment with the eye doctor after a failed vision screening would be important, and then also helping to keep follow-up appointments as well. So this sounds like a lot of documentation, and perhaps it is. So one thing that I'd like to reassure you about is that the website, if you go there after the webinar is over, you will see a very good comprehensive example of what one of these permission forms can look like. And this would be a good resource for you to look up when this session is done. On the slide that you see here, there is a portion of page 1 of the example document on the website. I've highlighted in red the consent wording, and you can look at the website later and see this in more detail, but with a single signature below, the parent does provide permission for you as the screener to communicate with all parties involved in that child's eye care, as I indicated earlier. And then on the second page of the document, you'll see additional information that will be useful for you as well. At the top, there's a portion where you can insert the child's information. In the middle there, where you can put your own information in. And then towards the bottom there, the eye exam information coming back from the eye doctor. And then I skipped over the reason for the referral. Why are you referring one of your children to an eye doctor? And there's several choices there. The more common reasons are enumerated, and there's a line, of course, if you have a concern that's not enumerated above there. So it's a simple message that I have to deliver today, but it's a very important one. The visual screening process only works if there's not just a good visual acuity screening in place, but also if there's good communication between parties. And in order to create that communication, there has to be good documentation backing that up. So I thank you for your attention, and I will relinquish the webinar to the next speaker.
Thank you, Dr. Bradford. And thank you for pointing out the resources on the website. And I encourage everyone to, after the program today, to go to that website. There's lots of information. There's information that you can give to parents, which would certainly help them understand the importance of follow-up. There's pamphlets for the signs of eye problems in English and Spanish, family fact sheets in English, Spanish, and Chinese, and hopefully you'll find a lot of these materials helpful as you work within your own programs. So next, we will hear from Dr. Kate Chaplin, and Dr. Chaplin has a doctorate degree in special education. In addition to her work with Dr. Bradford and also with the Good Life Company, she is also a vision screening consultant for School Health Corporation. She has lectured, trained, and consulted at more than 100 national and state educational venues, including the National Head Start. Welcome, Dr. Chaplin.
Hi, hello everybody. Thank you so much for giving us your time this afternoon. So I'm going to be talking about evidence-based vision screening protocols and guidelines. Once I can advance the slide. Sarah, you want to help me here? Okay, great. So there is the third component of the vision health system, and you will notice that this is the screening piece, and it's only one piece of the 12 components, so it's an entire system. Oops, I've got control now. Types, which are pictures and or instruments, 2 bullets on vision screening procedures. So there's actually 2 types of vision screening. We have optotype-based and instrument-based, or a combination of both. And Dr. Lawrence will be going into more detail on the instrument-based. So optotype, which by the way came brain level, instrument-based screening measures for the presence of amblyopia risk factors such as significant refractive error, asymmetry of refraction. Supports using single lay assembles up to 5 years. So this is one example. If you can see my mouse, this is from the VIP study. This is eye check, also conducted at 5 feet, was developed by Wendy Marsh Tootle, an optometrist in Alabama. And this is iSpy 2020, which although it's at 10 feet, it's still using the single crowded optotypes, and it is software with a huge database collection capability. Oops, Okay, so within optotype-based screening, there are two different methods. One is threshold screening, and here's an example of a threshold chart. And what you're doing here is you're starting at the top and you're moving down the chart until the child can no longer distinguish one from another or correctly identify the majority of optotypes on that line. Then you have the option of critical line screening, which means you're just asking the child to identify those optotypes on the line that the child should pass according to age. And this is an example here, one of Dr. Ramsey's tests out of Massachusetts. Here's another example. This is the APOS kit, and you'll see the threshold here and the critical line here. Now these are Sloan letters, but there's also critical line for LAIS symbols here, as well as critical line for your Sloan letters. So threshold screening and critical line screening within optotype-based screening. Okay. Having a little bit of technical difficulty. Here we go. So many of you, we know, use threshold eye charts as a test of visual acuity. So my session is going to be primarily on threshold eye charts. So it's very important that you know that an eye chart is not an eye chart is not an eye chart. That the design of the eye chart can significantly affect the visual acuity scores that you receive. And on an eye chart, excluding the optotype size, each visual acuity level should present an essentially equivalent task. And I'll get into that and explain what that means. I apologize to you guys for this movement. So standardized eye charts that meet national and international eye chart design guidelines will offer this equivalent test task. However, the problem is that many of your commonly used eye charts do not offer this equivalent test task. So if you're using an eye chart for optotype-based screening as a test of visual acuity, how do you know if the eye chart you're using is standardized? Well, there actually are guidelines to specify how those charts should be designed. And there are guidelines from 4 different groups. We have 1980, the National Academy of Sciences National Research Council, 1984, the International Council of Ophthalmology with input from optometry. We have guidelines in 2003 from World Health Organization, and the most recent 2010 from the American National Standards Institute. So when you combine the guidelines from all of those groups, you want to advance me, Sarah? Thank you. Whoops. Oh, I'm so sorry. Okay, so when you combine all of these guidelines, these are the guidelines. So your optotypes should be approximately equal in legibility, and this means that you want an eye chart that has optotypes that cannot be guessed. In other words, if they're almost equal in legibility, you won't have issues with guessing what the optotypes are. You want your horizontal between optotype spacing, I'm looking at this block here, to be 1 optotype wide. So in other words, the spacing here would be equal to the width of this optotype. You want your vertical between line spacing, the space here, to be equal to the height of the next line down. Another guideline is that your geometric progression of optotype sizes should go up and down the chart in 0.1 log units. The only thing you need to know about that component is to look at the 2032 line on your chart, and if it says 2030, you're not meeting this guideline. It should say 2032. You want 5 optotypes per line. You will see charts that may have 3 or 4 on the top 2 lines, and that's okay because it's fitting the size of the chart. Usually you'll see that in a 9 by 14 chart. You're more concerned down in this area, if you can see my mouse moving, so you want 5 optotypes per line. You want your optotypes to be black on a white background with a luminance level between 80 and 160 candelas per meter squared. Now, I don't expect you to purchase a light meter and check your area. Just make sure you have good lighting. So some quick tips for knowing if your eye chart is standardized and correct. It's inverted pyramid. If you drew that line and this shape here on the left. So you also want to see, does your chart say 2032 instead of 2030? And your chart will be at a 10-foot distance between the child's eyes and the chart and not 20 feet. Now it gets a little confusing when you're giving the visual acuity. The left-hand side will give you the 10-foot, the actual measurement. The right-hand side will be the 20 over X Snellen notation, and that's the number that you would actually report. So I'm going to talk today about challenges with 5 common eye charts, and I put up Snellen because I do know that some early childhood programs do use Snellen. We want to refrain from doing that. So these are just 5 common eye charts. If you happen to have questions on the eye chart you are using, I supply my email at the end, so you can always send those to me. So when we're looking at Snellen, notice Snellen charts, because we have more than one design of a Snellen chart. It is not, those charts are not standardized. They do not meet the international national guidelines. Some optotypes are easier to guess than others. You really don't want to be using letters with children in the 3 through 5 year old age group, or at any time before children are comfortable with their letters, or that may stop them in their tracks and they don't want to talk to you. So I mentioned the cell boat because that one's used. I haven't tested this exactly, but just what I know from attending different conferences, this chart is used very often in pediatric primary care practices. Challenges here. This chart does not meet the national and international eye chart design guidelines. You have optotypes of different sizes on the same line. If you look down here, you'll see how much larger the hand is than the star and the cup, for example. The American Academy of Pediatrics, along with other groups, have been recommending lists of eye charts since 1972. This eye chart has never been on that list. I have, and in my spare time, I actually study eye charts and look at who developed them. Idea who designed this eye chart. I spent the last 3 years trying to find out, but I still don't know. So if any of you all know, please pass that information along. There's also no supporting research to validate. I did find 3 studies, but they don't support it at all. If anyone wants more information on those studies, let me know. So now we're going to talk about the tumbling E. So with the tumbling E, of course, you're asking the children to tell you the direction of the table legs or whatever you're calling that E. So you need to know that children's orientation and direction is a cognitive skill that is emerging over time. So when you're asking children to use their hands or a replication of this optotype, pointing or moving that in the correct direction is very difficult. And also the direction, so that compounds the movement. So again, this is an emerging cognitive skill. Up and down emerges before left and right. All of that, you're actually testing cognition and not vision. The second challenge is there is the ability to guess at the optotype. Remember, one of the guidelines is that you want the optotypes to be as nearly equal as possible in legibility. So if you ever have the opportunity to look at this chart at a distance, and you can tell by looking at either, when you get down in this area, more information on this than I'm presenting today, But the issue with Allen pictures, first of all, you're asking Snellen 30-foot E and not the Landolt C, which is the international standard. So any optotypes should be calibrated against this chart to make sure that they are sized correctly and so forth. So looking at the Lighthouse visual acuity results using the Landolt C, they were not as good when you looked at that comparison, and that's also mentioned in this study. So if you recall, in the pediatrics, the American Association of Certified Orthoptists, the American Association for Pediatric Ophthalmology and Strabismus, or APOS, and the American Academy of Ophthalmology. So this chart, the Lighthouse chart, is not on that list. And HOTV. Leia symbols happens to be the only pediatric eye chart with optotypes that blur, and they blur usually to circles. The neutral, children call them what they want. For example, this square might be an iPad, this circle might be a hula hoop. You accept whatever name the children provide and use that one. You don't want to use single optotypes or for developing children. Some people will use these. I'm going to talk about children with disabilities and special health care needs and how those children should be handled within this vision system. So a couple studies here found that when you looked at the visual acuity results using flashcards or single optotypes versus a chart with lines, that the visual acuity results on average were 3 lines worse, meaning that they may have a 2032 on a single isolated optotype, but actually a 2080 on a line chart. So don't use single optotypes without crowding bars or flashcards. So now I'm going to move quickly into occlusion. When children are very likely to peak when you give them responsibility for their own occlusion, and they're not being bad. It's just if you're covering the good eye, if you will, and having them look at the chart with the bad eye, if you will, they don't want to look at that if that vision's blurry. Here, don't ever use the hand as an occluder. Too many issues with that I won't get into today. So the recommended occluders for this age group, particularly under age 10, would be some kind of an adhesive patch or medical tape or occluder glasses. And you can't tell in this image, but one eye is covered with a frost variance. I have never had a child want to take these glasses home with them. So anyway, these are the types of occluders that would be best to cover the eye when you're doing screening. So now I'm going to move into 3A, which is to follow your national referral and rescreening guidelines. Now this is an example. This is from that 2003 policy statement that I mentioned earlier. The recommendation here is that the children ages 3 through 5 years should be able to identify correctly the majority of optotypes, or 3 out of 5, on a line with 5 optotypes on the 20/40 line with both eyes. So in other words, when you're screening monocularly, both eyes need to be able to identify the majority on the 20/40 line. Looking at 6 years and older, that is 2032. Now this is an example because you may see additional guidelines where this number might be different, but this is an example. So now let's talk about, moving ahead too quickly, talking about untestable children, or those children who are difficult to screen. The VIP study, the Vision and Preschoolers study that screened thousands of Head Start children, found that untestable children were twice as likely to have vision problems than those who passed vision screening. So twice as likely. So don't lose those children. If you can't screen them, either rescreen or refer. So if you have a reason to believe that the child may perform better on another day, consider rescreening the child within 6 months. Otherwise, refer untestable children for an eye exam with a pediatric eye care professional who is skilled in treating young children. Moving to 3B, you want to ensure that vision screening training for your staff leads to certification and evidence-based vision screening. So basically, first of all, you want to make sure that your staff have been formally trained. Too many times when I'm out lecturing and I ask folks how many were formally trained, 1 or 2 hands may come up. Usually the person who was there before told them how to screen, or they read the manual the day before. It's important to have formal training because the World Health Organization recommends regular training for screeners because the skill of the tester affects very significantly the validity and variability of the outcome. So check to see if there's a Prevent Blindness affiliate in your area, or look at some training certification programs from state-designated trainers such as public health departments. Dr. Bradford and I were asked to write an article for NASN School Nurse. So here's another resource that talks about charts, threshold charts for tests of visual acuity. So that's a resource for you. Again, as mentioned earlier, lots and lots of resources on the Year of Children's Vision page. And I thank you very much for your time and attention. This is my email address and telephone numbers. I certainly welcome your questions, and thank you so much. So I'm ready to move on to the next presenter, and I wish to introduce to you a good friend of mine also who is phenomenal in the work that she does, Dr. Linda Lawrence. Dr. Lawrence, take it away.
Let me just say a few words.
Oh, sorry, Jean.
Dr. Chaplin has well, first off, I just wanted to say, Kay, that presentation was wonderful, and those of you who have heard it, be important to go back, look what charts you're using, what charts folks are using, because it really is a shame when folks put a lot of effort into screening vision, and in truth, they won't be able to pick up the children with problems because they're mistakenly using charts that won't work. And it's only because they don't know, they don't have the knowledge. So all of you today can now share your knowledge. So with that, I would also like to introduce Dr. Lawrence, and she is in private solo practice in Kansas, and for over 25 years she has worked in birth to 3 programs providing screening, assessment, and intervention for children with multiple disabilities. She has worked internationally for over 15 years and has trained ophthalmologists in Panama and Nigeria on how to evaluate vision in children with neurodevelopmental disability. Welcome, Dr. Lawrence.
Thank you very much. I'm really excited to see this many people attending this webinar, and I think it really speaks highly to what we as team members want to do, which is ensure the best visual potential for our children. I'm going to discuss today, let's see if we can get the slide to change, screening with age-appropriate and evidence-based tools, how to create vision assessment policies for children with special needs, and when to refer untestable children. And the slide's changing. This is an important reference for you. You can get online. It's the new 2012 American Academy of Pediatrics policy statement on instrument-based screening of vision. It states that photo screening may electively be performed in children aged 6 months to 3 years. And photo screening is recommended as an alternative to visual acuity screening in children ages 3 to 5 years. But we need to remember that visual acuity screening with optotypes, or what we, as Kay explained, what we used to call eye charts, is preferred in children above 5 years of age. Charts for vision screening means evidence-based optotype. So what is the difference between vision screening and vision screening devices? Vision screening with eye charts or optotypes, again, tests visual acuity. Vision screening devices do not test visual acuity, okay? They are instruments that test for risk factors that may cause decreased vision or amblyopia, such as refractive errors, strabismus, cataracts, etc. But they do not test visual functioning. And for children with multiple disabilities, visual functioning is very important. Devices fall into one of two categories. There we go. Photo screeners or autorefractors. So what is the difference? Let's talk a little bit about the difference, remembering that neither replaces visual screening with optotype testing. And we can go to the next slide. A photo screener is an instrument that takes a photo of the eye's red reflex, as you can see in this child, similar to the red reflex you would see in a camera. And this estimates the refractive error. The refractive error is the prescription of the eye. It can also detect ocular misalignment and other conditions that would block the line of sight, such as a cataract, and it measures both eyes at the same time. Next slide. Photo screening uses optical image of the eye's red reflex to estimate the refractive error, medial opacity, ocular alignment, this is what we would call strabismus, and other factors that put a child at risk for developing amblyopia. Again, it's measuring risk factors. It's not measuring the actual child's acuity. And these are some different types of photo screeners that are on the market. We're really not in the position to recommend any particular device. Go to the next slide. Let's talk about autorefractors. Well, actually, this is a photograph that shows a photo screener, and the child has farsightedness, and it's indicated by crescents formed in the red reflex. And you can see that this is a test that needs to be interpreted by an experienced reader. As far as the autorefractors, these are instruments that determine the refractive error of the eye. So this is the actual prescription of the eye. High or asymmetric refractive errors can cause strabismus and amblyopia. These machines can also detect other conditions that may block the visual axis that can lead to amblyopia and loss of vision. The downside being that most instruments can measure only one eye at a time. Next slide. Autorefraction evaluates the refractive error of the eye. The National Institutes of Health-Sponsored Vision Preschooler Studies systematically evaluated instrument-based screening methods and compared them with visual acuity-based screening when administered by licensed eye care professionals. Remembering that a disadvantage of autorefractors is that they typically measure only one eye at a time, and this can limit the ability to detect strabismus. However, in contrast to tabletop autorefractors that you see here, some of the new handheld ones are very useful for screening young children. One of the disadvantages of these that we have in our children with neurodevelopmental disabilities is their inability to actually fixate on the instrument. And in some of the instruments, the fixation devices, such as in the Plus Optics, which may have a face, may actually be offensive to some of our kids. In the next slide, we'll ask the question, what do you do if the child does not pass the test? First of all, you have to ask yourself, have you done a good screening? Was the test age and ability appropriate? So what do we do next? Next slide. Your options are to, number one, refer the child for a comprehensive eye evaluation. Number two is to screen with a different test. Number three is to screen again at a later date. And last is to pass the child, which should never be done if they fail to screen. For preschool children, we know that if they're unable to perform the vision screen, that they are more likely to have vision disorders. And so this is the reason that they need to be referred. You may not know if it's behavioral or learning related, and data does not show if it's better to screen with another method or refer. If we can go to the next slide, I seem to have lost my screen. Sarah, do you have any ideas for me? I seem to have lost my screen.
Linda, when you say lost your screen, you can't see it,
While
or
we're
lost
getting
control?
there, I could lead you a little bit. Do you have it now?
No.
Okay. Under your options, you talk about options for rescreening if the child is ill or not able to do it on that day.
Yes, and I can go through them if you want to just change the slide. So we know that as the options as a screener, you can rescreen because you'll know if the child's obviously ill or not able to do the test on a specific day. So next you have to decide, is it best to do a different test or a different day? This may depend on the availability of your test or resources. And rescreening should be done within a few weeks. We all need to, as screeners, remember that screeners do not diagnose. They refer if the child fails the screen, and screeners should not interpret the test. So if we go to the next slide, who do you refer to? You need to define appropriate referral patterns. As Dr. Bradford stated, having permission for communication with a primary care provider or eye care specialist is very important. Your pediatrician may use the same screening technique, so it may not be helpful to send only to the pediatrician. We need eye care specialists that are experienced with young children to be the first referral. Really, before undertaking a screening program, a list of possible referral sources which are child-friendly should be put together. This should include what insurances the providers take. Are they taking new patients? Or does the child already have an eye care specialist? The child who fails the screen needs a comprehensive eye evaluation with dilation to examine the health of the inside of the eye, or what we call a fundus examination for pathology, and to determine exact refractive needs. If you make direct referrals to specific providers, you may be responsible for the fees. If we go to the next slide, and we ask the question, should children with known ocular disease be screened? Kind of an interesting question, but as a screener, if the child has glasses or if there's a concern about their business, actually screening may detect interim changes. I've talked to a lot of parents about this, and inclusion in an activity that other kids are participating in at a center seems to be very important. Parental education is needed because some parents feel if they're bringing their child already to an eye care specialist, it's not necessary to have additional screening, and they may feel the time and expense to justify this. But many parents do not want their child excluded from any activity that others may be involved in, regardless of ability. If we go to the next slide, who should bypass vision screening and go directly to an eye examination? I want to emphasize here that there are high-risk children for eye disorders. These high-risk children may not be able to do any of the vision screens, whether it's visual acuity, with optotypes, or with a instrument-based screening. What we need to realize is that children with developmental delays or other risk factors have a greater probability of vision problems and should go directly to the eye care provider who specializes in caring for these children. They need comprehensive eye examination. Parents really need information to understand the increased risk their child may face. And an interesting thing is if you have to screen to refer, then you may need to screen these children even though you know they already need a comprehensive eye exam, if that makes sense. If we go to the next slide, Example of children who have already failed even before they are screened include children with Down syndrome. These children have a 90% risk of eye disorders. Also, children with juvenile arthritis who may have undetectable eye disease by screen, and neurofibromatosis. If there's a family history of eye disease, including amblyopia, strabismus, retinoblastoma, which is eye cancer, congenital cataracts or glaucoma, these children should go to an eye care provider. And again, children with developmental delays or disabilities, intellectual disabilities, neurophysiological conditions, or other behavioral issues that render them untestable are at a high risk for eye disorders. They need to be referred. If we go to the next slide, other high-risk infants include premature infants. Infants born premature at a greatly increased risk of eye disease, especially if born below 37 weeks gestation. Those with low birth weight, prolonged supplemental oxygen, or grade 3 or 4 intraventricular hemorrhages, or intrauterine growth retardation are at high risk, along with those who had retinopathy of prematurity, even if the retinopathy regressed. If we go to the next slide and talk a little bit about children with neurological disabilities, what we know is that there's no consensus as to the best method of assessing vision in children with neurodevelopmental disabilities. Comprehensive eye examination is indicated along with functional visual evaluation. Eye care providers may do retinoscopy, other tests of accommodation, pupillary exam, oculomotor exam, including saccades and pursuits, etc. And these are all necessary in our kids with neurodevelopmental disabilities. If we go to the next slide and talk about high-risk maternal behaviors, these may be also reason for referral for complete examination of child. For example, children of mothers who smoked or used street drugs or alcohol during pregnancy, had rubella, toxoplasmosis, venereal diseases, herpes, cytomegalovirus, or human immunodeficiency virus during pregnancy, or mothers who experience difficult or assisted labor with fetal distress or low APGAR scores may have children with high risk of visual problems. Other child risk factors may include known or suspected central nervous system dysfunction, such as developmental delay, cerebral palsy, dysmorphic features, seizures, or hydrocephalus. Children with autism spectrum have up to 25% incidence of refractive errors or other eye disorders, and this may be difficult to assess with optotypes or devices. Also, children diagnosed with attention deficit hyperactive disorders may be difficult to screen with either type of screening method. If we go to the last slide, as Dr. Bradford said, communication and family support are essential. Parents' knowledge of importance of further examination warrants further education. Common parental questions include multiple economic questions like, who will pay for the examination? What is the role of Affordable Care Act? Who pays for the interventions, for example, glasses, patching, and follow-up examinations? Some parents may not want their child to wear glasses, patch, have eye drops put in. So if the child fails the screen, appropriate referral protocol must be in place. Education of parents and screeners are important. Children in special education have unique risk factors and behaviors that make routine screening by instruments or optotypes challenging and should be referred for comprehensive eye examinations. We need to develop appropriate screening protocols for children with multiple disabilities. But in the meantime, please consider early referral to child-friendly eye care providers for complete eye examinations. And we can move on. Thank you very much, and sorry for the slides.
So thank you very much, Dr. Lawrence, and thank you all presenters. And now we're going to move on and see if we have some questions out there. And I'd like to introduce you all to Kira Baldonado. She is the Director for the National Center for Children's Vision and Eye Health at Prevent Blindness America. Kira has been monitoring the questions, so I will throw it to her. Kira? All right, thank you, Jean, and thank you everybody for your wonderful questions that have been coming in. I'm trying to find themes, but there's a lot of great different questions throughout, so I'll try and cover as many as possible. One of the top questions that I'll open up to the presenters is how do we handle the requirement that Early Head Start has in screening the 0 to 5 or 0 to 3-year-old age group? A lot of them that we've discussed so far are really appropriate for 3 through 5. So how would you respond to those questions? Who would like to take that? Jeff, do you want to take that? If not, Dr. Lawrence, would you like to take that? How do you handle the requirement for screening 0 to 3, and our folks at Early Head Start have that requirement? So what is the best way for them to handle that?
You know, state by state, either the Department of Ed or your early intervention program, whatever that is in your state, has screening guidelines. In our Birth Through 3 program, where of course this is a Part C program, we have developed a very specific visual screen, but it's based on what our state requirements are. These are mostly visual functioning and developmental test rather than an optotype. Again, in some cases with experienced screeners, in 6 months to 3 to 5-year-olds, instrument-based screening can be used to look at things like strabismus or asymmetric refractive errors. But each state will have very specific requirements for their Birth Through 3 program.
Dr. Ramsey here. In looking at the results of the National Head Start Survey, which we will be presenting at the National Head Start meeting, it seemed like a lot of the Early Head Start centers were actually using some instruments to do this. And clearly, Kira, this is an area that needs more guidance, and we hope over, in the future to be able to offer more guidance in this area that's evidence-based for folks out there. If there's no more comments, we can move on to the next question. Certainly. I'll direct this question to Dr. Bradford if he's still on the line.
Yes, I am here.
Wonderful. We had a question around the parent permission. One of the individuals on the webinar provided a permission or notification to parents through their newsletter and information at the beginning of the year, and provided an opt-out at that point in time. Is that adequate, or is written permission necessary, and if so, what's the benefit?
I'll give an opinion. I'm not sure that it's applicable across all scenarios, but if the parent has provided permission at the beginning of the school year, I think that would be adequate for the screening. I'd have to be able to look at the entire wording of the consent, and this is more of a legal document than it is a medical document, but the entire consent form would also have to include the caveats of who that information can be shared with. And it's not clear to me from the question whether all of the bullet points that really are necessary to communicate between all parties were really enumerated at the beginning of the year in that specific consent. But in order to do the screening, it would be my opinion that at the beginning of the year, opting in or opting out is sufficient consent for the screening itself.
Okay, thank you. And Kay, I have a question directed to you. Somebody was paying attention when you said that you need to have a standardized approach to the number of optotypes on a chart, and notice that iSpy includes 4 optotypes versus the 5 you discussed. Does that impact the validity?
Okay, so that's a good question, and I don't have an answer. I can tell you that if whoever asked that question, if you will email me, I can send you, or anyone who wants this information, I can send you studies that have been done with the iSpy. It's software and not like an eye chart. The child, I don't have an answer to that, but that is a great question.
Okay.
Kay, if there are, this is Dr. Bradford, if there are 4 optotypes, then it would mean that the child would have a chance of giving the correct answer. Say the child had a blindfold on over both eyes. They would be able to correctly answer the question, what's the optotype, 1 out of 4 times. So 25% of the time they would guess correctly. So the chance of the screener missing amblyopia would be a little bit, statistically it would be a little bit higher if there were only 4 optotypes. If there were 5 optotypes, the chance of correctly guessing all of them would be statistically quite small, but it would be even smaller if there were 6 optotypes, and even smaller if there were 7 optotypes. So it's a statistical game between how many optotypes is optimal. The equation is for statistical validity on the one hand, and for cooperation and attention on the other hand. So a line of optotypes that's 4, 5, 6 symbols long is probably adequate, and we can let the statisticians decide whether one is truly more valid than the other on a practical standpoint.
Thank you, Dr. Bradford. I just want to mention we do have Rich Turendi on the webinar as well, and he just wants to add that iSpy 2020 was independently validated by the Storm Eye Institute, and from what they found, the 4 optotypes do not impact the accuracy. So thank you for that additional comment. Also, I'm going to go back to Dr. Lawrence for a moment. You made a statement in your presentation that a program may be charged if CSA refer to a specific provider, and there was a little confusion around that comment. Can you clarify that for the group?
Well, yeah, we actually have the experience here in Kansas where I was working with a co-op, and we saw children with disabilities, and they stopped the program because they were basically told if they organized a clinic with me, even though I was actually doing it at no charge, that there was the potential that the school district would have to pay the fees if they were bringing the children to the eye care specialist. So it's something that you have to be sure, first of all, you're doing the screening, you're making referrals. If a school makes a referral, you have to be careful it's not included in part of an IEP plan as something that the school has to pay for. So it's just kind of unusual situations. People do screening and referral in all different ways to try and help kids get access, and you have to look at your own system. This was just a problem in our system here. Does that make sense?
I think so. Thank you. Along the lines of the questions around a referral, I know there were some questions that came in or comments that came in when we said those children that may have an obvious problem should be directly referred to an eye care provider. Just a few statements came in that in some states, children that have Medicaid as their coverage option may require a primary care provider referral for them to be able to access the eye care services. Were there any additional comments that either panelists wanted to add to that?
This is Dr. Lawrence again. I think this just shows, state by state, our requirements are so different, and even community by community. We have in our own state, part of our birth through 3 programs are with Department of Ed and part with Department of Health. There's different insurance requirements, and you really, the screeners in advance should know their own system so that they can help guide the children and the families into the proper follow-up in the system. It doesn't do any good to just screen the children if you don't have the follow-up system in place. But I think it's unfortunately part of the screening is to find out what you're going to do when that child fails, or if they're a high-risk child, how to get them into the system.
Excellent. Excellent.
And if I may interject and add some information, also this is Kay. Sometimes what you need to do, and they have to go to the pediatric primary care provider first, is to try to get an idea of what is being used, because I had a situation where a screener using an appropriate tool had to refer the child on the pediatric office was using an inappropriate chart. The child passed, and the child then was unable to go on for the eye exam. So just tossing that out for something else to think about.
Thank you. I have some questions around what might be appropriate for use in the preschool population, 3 to 5. We've had several questions come in around the use of TIPness or optech machines. So anybody would like to address the appropriateness of those machines for this preschool age population?
Well, I can take that one unless someone else wants to, but Jeff Bradford again. I guess I'm the only male on here, so so the TIPness machines are widely used, and in large part, I think, because it's a device that can be set on a table in a relatively small room, and spaces in pediatricians' offices can be quite cramped. And even a 5-foot testing distance for visual acuity screening on an eye chart can be difficult to arrange in a very tight office setting. So the TIPness machines are popular, I think, because they do sit on a table quite nicely and can have a dust cover over them, and the children can be brought in very easily to set in front of the device. I would have to say that I can only offer my own personal experience, and that is that the kids who are, let's say, 6 years old and older tend to do the TIPness testing pretty accurately. The younger children, especially the really young children, 3 years old, 4 years old, they're often more intrigued by the machine itself than they are able to cooperate for the instructions to read what's inside the machine, what's being displayed, because there's no way for the office nurse, the screener, to really tell exactly what the child is looking at, because the child has to look into the machine, and the screener can't see in the machine at the same time. So I think the attention span of a preschool or kindergarten child is probably not uniformly sufficient to do an accurate TIPness testing. So I think a wall chart where the screener can really assess the child's attention to the screening is the more accurate way to go with the little ones. But I have to admit, I don't see a lot of youngsters who falsely fail a TIPness test when they're first, second, third grade, etc. Perhaps Dr. Lawrence or Dr. Ramsey would also like to interject, since this was just one person's opinion as I'm expressing it.
Yeah, this is Dr. Lawrence. I don't have much experience with the TIPness test.
Well, the only other point is, Dr. Ramsey here, I would raise, in Massachusetts, that was being used widely, and this was years ago. In addition, Jeff, to the problems you're raising, there's also the problems of the small face doesn't really fit in there all that well, and in truth, if you're checking the right eye, if you look away for a split second, you may not be getting the vision for the right eye. So I think it's very difficult to be certain that you're testing what you're testing. There are some other problems, too, in how doctor types are presented in those machines. But so we do not recommend they be used in the preschool population.
Right. Yeah, I'm going to share that exact opinion with you. Yeah. It's good for when you go to the the Division of Motor Vehicles and get your driver's license eye screening done, but it's probably not the best device for use for very young children in vision screening.
Just one point I wanted to get out to the audience. I know that we won't be able to get to everybody's questions today. We had quite a few come in, especially here at the end. But if we aren't able to get to yours, we will try to get back to you via email addressing your comments and questions from the webinar. Just one final point. Several people asked where they would be able to get the forms, the information that was discussed on today's webinar. And that will be on the Year of Children's Vision website, and that link, I believe, will be sent out with the link to the recording. So you will be able to get that. Some of the forms are in English only, and we've had a request for that consent form maybe in Spanish, and I imagine it will be helpful in Chinese as well. So the National Center will work on getting those up in the next 30 days. Okay.
Great. Okay. Thank you, Kira. I just want to make a mental note. We've talked about some things that we don't recommend, the lighthouse chart, the TIPMIS, et cetera. And I just want to make it clear to everybody who's attending the conference, this is not meant in any way to be critical of folks who are using this. I would say there's been a void. People did the best that they could. You know, they knew it was important to check vision, and they did the best that they could. And it's our job to make sure that we get the information out there so that people can do an even better job. So Sarah, do you want to wrap it up here?
Sure, thank you so much. We would just like to thank everyone for attending today. We had a fantastic attendance rate. And as Kira mentioned, just watch for that email. It'll probably come in a couple days. I know everyone's eager for the materials, but we need to compile all of the resources, and we'll send that out to you here in a couple days with the recording, a link to the YOCV page, your certificate of attendance, and the presentation slides. And that is it for today. We'll be ending the session, and we will also work to follow up on some as many questions as possible that we received that we weren't able to get to today. So thank you again, and we will be ending the session now.
So I just want to also end by thanking the presenters. You all did a terrific job with lots of valuable information. When you go to this website, you'll also see prior webinars that have been done, prior radio podcasts, etc. Lots of information there, and more will be coming. So thank you again. We appreciate you joining us, and have a good night.